The basic methods used to reimburse healthcare providers could be classified into 8 types of payment, and they are 1. Per time period, common terms being budget and salary. For example, salaried physicians in government hospitals. Number 2, per beneficiary, common terms being capitation. For example, managed care organizations' payment to a non-employee physician. Number 3, per recipient, common term being contact capitation. For example, physician specialist services. Number 4, per episode, common terms being case rates, payment per stay, and bundled payments. For example, Medicare's diagnoses-related group and resource-based relative value scale. Number 5, per day, common terms being per diem and per visit. For example, payments for nursing facilities. Number 6, per service, common term being fee for service. For example, payments for physician services, dentists, medical equipment, and supplies. Separate payments are often made for multiple services per day. Number 7, per dollar of costs, common term being cost reimbursement. For example, payments for critical access hospitals, government-owned providers, and nursing facilities. Payers typically pay a percentage of costs as allowed by the payer. Number 8, per dollar of charges, common term being percentage of charges. This method of payment can be used for any provider type. It is based on charges as billed by the provider. The acronym I created with the first letter of every payment type is the best revenge ever doesn't solve diddly do. The best revenge ever doesn't solve diddly do. The 8 basic methods are comprehensive and mutually exclusive because each method uniquely corresponds to a risk factor within the healthcare spending and identity. Like other accounting identities, this identity illuminates the relationship between the whole and its parts. Using inpatient care as an example, total hospital charges depend on several factors, including the number of inpatient episodes, the average length of stay, and hospital's markup of charges over costs. So in parallel, the 8 basic payment methods include Method 4 per episode, Method 5 per day, and Method 8 per dollar of charges. So what this means is the hospitals and facilities and such, they will charge based off of the type of services or what they are going to be doing. Like in this example, for the inpatient, that's per episode. Also, it could be per day, depending on how many days that they're inpatient, and then per dollar of charges too, which is number 8. So this, like I stated, is parallel to the payment methods. So depending on what they're charging for, kind of depends on, it's also dependent on how we're going to pay. So they're very closely related. So dividing financial risk. So because very few services are wasteful always and everywhere, providers presumably are the best judges of right care, right time, right way, so as long as they have the appropriate incentive. Thus, Medicare shifted risk toward providers in 11 of the 13 payment reforms since 1983. These reforms have had broad influence because many payers emulate Medicare. Changes in basic payment methods can have sweeping effects, both good and bad. Now, Medicare decided to change how they covered inpatient payments. So Medicare used to pay according to hospital costs, which are per dollar of cost, to paying for diagnoses-related groups, which is method number 4, so per episode. And then the diagnoses-related groups, or DRG, is a case mix complexity system implemented to categorize patients with similar clinical diagnoses in order to better control hospital costs and determine payer reimbursement rates. Payments by DRG led to decreased hospital costs, shorter lengths of stay, reduced growth in Medicare payment, and even increases in hospital margins, which is a surplus of revenue over cost as hospitals became more efficient. But dig this. This payment change also accelerated the growth in outpatient and post-acute care services, possibly increasing fragmentation of care. Fragmentation of care means the systemic misalignment of incentives or lack of coordination that spawns inefficient allocation of resources or harm to patients. So pretty much what this is saying is, if Medicare is paying a certain way, then providers can either charge more services based off of their payment. It's pretty much, they react according to the incentives. Like, all right, is it in my best interest to do this because I'm not going to get paid if I do it? You know what I'm saying? So this in the long run could actually end up hurting the patient, because say, for instance, the provider's getting charged per service. So they might have them coming in for getting all these different services that they really don't need, just because they're getting the incentive of being paid per service. This is actually very, very interesting. So it's like, excuse me, you have to find a good balance between both of them. So providers are getting incentivized for doing the work, because the goal is to have providers provide the best care thinking about the patient, not necessarily thinking about the money that they're going to get in return.